All right, let's dive into a condition that's a real medical puzzle, especially when it shows up in kids. It's called childhood nephrotic syndrome, and it often kicks off with a single, really alarming symptom that can pop up almost overnight. We're going to unpack this complex kidney disorder, and we'll use some fascinating data from two key studies in Nigeria to see what it is, how doctors diagnose it, and how the story of this disease is actually changing for the better. So, just picture this for a second. What on earth could make a child swell up, almost from one day to the next? Their face, their belly, their legs, suddenly puffy and swollen. This is the exact question that sends panicked parents rushing to the doctor. And it's really the first clue in the clinical detective story we're following today. This swelling, what doctors call edema, is the most obvious sign that something is going seriously wrong with the body's super important filtering system. So the condition behind all this is called nephrotic syndrome. And in medicine, it's defined by a classic group of 4 signs. First up, you've got heavy proteinuria, which just means a ton of protein is getting lost in the urine. Second, because all that protein is escaping, you get what's called hypoalbuminemia. That's just low levels of protein in the blood. Third, you get the edema, that swelling we just talked about. And finally, number 4 is hyperlipidemia, high levels of fat and cholesterol in the blood. These 4 clues all point back to one single problem with the kidneys. Now, you might be wondering, who does this affect the most? Well, this chart from a study in Uyo, Nigeria, tells the story pretty clearly. You can see a definite peak among young children. So while, yeah, it can happen at any age, nephrotic syndrome is overwhelmingly a disease of childhood. And that, of course, makes understanding and treating it incredibly urgent. Okay, so how do doctors actually figure this out when a child comes in with that kind of swelling? Well, let's get into the diagnostic playbook. It's a systematic process, really, of gathering evidence, and it all starts with a physical examination to look for some key signs. So during that initial exam, doctors are on the lookout for a specific cluster of symptoms. The most obvious, of course, is that generalized swelling, the edema. But they're also checking for hypertension, high blood pressure, which is surprisingly common in these kids. They'll ask about urine output. Is it really low? That's a sign called oliguria. They'll also check for tiny microscopic amounts of blood in the urine, and even for signs of a fever. Every single one of these is another piece of the puzzle. And check out this table. It gives us a really clear picture of just how common these signs are. This is from that study of 55 patients in UL. Look at generalized edema. Almost 95% of children had it. But also, look at how significant hypertension and low urine output are. They showed up in more than 2/3 of the patients. This data just confirms that these aren't just minor symptoms. They are core features of how this disease shows up. So after the physical exam, the investigation gets way more specific. Step 1 is a simple urine test. And this is the absolute key. Doctors are looking for massive protein loss. That is the essential clue. Step 2 is a blood test to confirm the low protein levels in the blood and to check for that high cholesterol we mentioned earlier. And then there's step 3, a renal biopsy, which is usually saved for the tougher cases, the ones that don't respond to the first round of treatment. That involves taking a tiny piece of the kidney to look at it under a microscope. All right, so we've seen how it's diagnosed, but what is actually going on inside the body to cause all this chaos? To understand that, we need to take a look at what I'm calling the kidney's leaky filter. Okay, think of the tiny structures in your kidney, called the glomeruli, as these highly sophisticated filters. In a healthy kidney, this filter is just amazing. It keeps all the valuable proteins like albumin inside your blood where they belong, while letting waste products and extra fluid pass right through into the urine. But in nephrotic syndrome, this filter becomes damaged. It gets leaky, and it starts letting huge amounts of protein spill out of the blood and into the urine. This loss of protein is the root cause of all the other problems, especially that dramatic swelling. Now, this is where it gets really interesting. Let's zoom in on the view from Nigeria, where our 2 source studies come from. By comparing an older study from a city called Yoyo with a more recent one from Abuja, a really important and kind of surprising story starts to emerge. It's a story of change. So what we have here are 2 snapshots in time. The older view from that Uyo study, which covered nearly a decade, found that it was common for kids to be resistant to the standard steroid treatment. It also found a link between the condition and infections, like malaria. But then you look at the newer view from the Abuja study just a few years ago, and it shows a very different picture. Now, a high rate of kids are responding to steroids, and those infection-related causes, they've become much, much rarer. And to put a number on that historical challenge, in the Uyo study, almost 31% of children were resistant to the main treatment, steroids. That meant their path to getting better was just so much harder, and it required stronger, more complex therapies. Now, get this. In stark contrast, the more recent Abuja study found that nearly 74% of children responded well to that very same steroid treatment. That is a massive, massive shift, and it suggests that something about the disease or its management is improving in a big way in the region. So the big question is, why this positive change? Well, this quote from the Abuja study gives us a major clue. The authors point out that malaria-caused nephrotic syndrome is now rare. This supports the idea that as we get better at controlling infectious diseases, the outcomes for this kidney disease get better too. Better public health is having a direct, positive impact here. It's fantastic news. So, this leads us to the verdict and the outlook for these kids. We have this tale of two responses. But what does it actually mean for a child to be steroid sensitive versus steroid resistant? This chart from the Abuja study really breaks it down for us. For the vast majority, almost 74%, the good news is they're steroid sensitive. That means the first-line treatment works for them. But for that other 26%, the steroid resistant group, the journey is just so much tougher. And this is the crucial thing to understand. The challenge of steroid resistance is enormous. For these children, treatment requires way more complex and expensive drugs. There's a much higher risk that the disease will progress all the way to end-stage kidney disease. And this is a sobering fact. In that Abuja study, all 4 of the patient deaths happened in this resistant group. Ultimately, it can lead to needing long-term dialysis or even a kidney transplant. And this quote from the UYO study adds another critical and frankly heartbreaking layer to the story. It points out a harsh reality: the inability for families to afford the investigations, the specialized drugs, and therapies like dialysis poses a huge challenge. This directly leads to poorer outcomes. It creates a barrier to getting better that isn't medical. It's economic. So let's pull all this together. What are the key takeaways? First, childhood nephrotic syndrome is a really serious kidney disease where the body's filters start leaking protein, causing that dramatic swelling. Second, diagnosis is a methodical, step-by-step process for doctors. Third, and this is the really hopeful part, recent data from Nigeria shows a clear positive trend. More kids are responding to standard therapy, probably because of better control of other infectious diseases. But finally, despite all this progress, access to advanced care for those really tough resistant cases is still a critical and sometimes life-threatening challenge. And that really leaves us with a final, bigger question to think about. The science and our medical understanding of diseases like this are clearly getting better. But as that knowledge grows, how do we make sure that every single child, no matter where they happen to be born, has access to the life-saving care that comes from that progress? That is the challenge that lies ahead of us all.